Hi, I'm Caroline, and today I'll be filming my pulmonary, cardiac, abdominal, and peripheral vascular assessment. So I have two volunteers here with me today. It's Kelly is my patient, and then behind you filming is Kayla, and she's gonna do a quick span of the room to show you there's no notes. Great, so we're ready to get started. So the first thing I'll do is do hand hygiene, obviously, and introduce myself to my patient. Hi Kelly, my name's Caroline. I'm the student nurse practitioner that's going to be completing your exam today. How are you feeling?
Doing great.
Awesome. So the first thing I'm looking at is his general appearance and his state. He is dressed appropriately, he's communicating with me, maintaining good eye contact. He doesn't appear to be in any sort of extreme pain or respiratory distress. I don't see any facial expression that would indicate pain, and no obvious distress, tripod positioning, nothing like that. So we're ready to get started. The first thing we're going to do is his lung assessment. So Kelly, if it's all right with you, I'll have you take off your shirt so I can get a better view. Is that okay?
Yeah.
Awesome. And we'll begin with his posterior chest. So I'll step over here so I can see his back, okay? So I'm gonna always start with inspection. So I'm just inspecting his skin on his back and looking at the shape of his chest from the back. I don't see any obvious barrel chest. I don't see anything on his skin like a laceration or a wound that would indicate recent trauma. And I don't see any use of accessory muscles here in the back. So what I'm gonna do next is percuss. Or actually first I'll palpate for tactile firmitis, and then I'll palpate also for thoracic expansion, and then I'll percuss. So I'm gonna look at his thoracic expansion first to measure his AP diameter. So I'm gonna place my hands right underneath his ribs here. Sorry, my hands are a little cold, Kelly. And I'll have you take a deep breath in and out. Great. So when watching my thumbs expand, I can measure how deep his breaths are to measure his AP diameter. And his was about 4 centimeters, which is average for an adult male. So that's great. Next, we'll palpate for tactile firmitis. So this is where I place my hands on his chest and I'm feeling for vibrations. So he's gonna say 99 as I feel for vibrations, and I'm feeling for any increased vibrations than normal that could indicate consolidation like a pneumonia. Okay, so I'm gonna palpate and go ahead and say 99.
99.
Again.
99.
Again.
99.
One more time.
99.
Great. So I didn't notice any increased tactile firmitis from what I would normally feel. Next, we'll percuss different regions of his chest to feel and listen for tympany versus dullness. Dullness, again, could indicate consolidation with pneumonia, okay? Great, that's fantastic. I just heard tympany throughout, no areas of dullness noted. So I'm gonna listen now and auscultate the various lobes on his posterior chest and listen for any adventitious lung sounds, okay? I'm gonna use the diaphragm of my stethoscope. So just take a deep breath. And again. Great, his lungs sounded clear to all lobes bilaterally. I didn't hear any wheezes, rhonchi, rales, nothing like that. So I'm actually gonna have you, Kelly, come sit over here so I can listen to the front of your chest. So again, since this is my first time looking really at the front of his chest, I'm just inspecting again, for any retractions, signs of respiratory distress. Sometimes you can see them subcostally or intercostally. I don't see any, and again, I don't see a barrel chest or tripod positioning that would indicate respiratory distress. So I'm going to go ahead and auscultate all of these lobes in your interior chest. Take a deep breath. Great, so again, lung sounds were clear and equal bilaterally to all lobes. So that sounds great. What I'll have you do next is actually lay down here. Great. And what I'm gonna first do is I'm inspecting his cardiac silhouette. So I'm gonna sit down and I'm looking for any heaves, lifts, or thrills, anything like that, which I don't see. Then I'll go ahead and palpate, trying to find the point of maximal impulse or his apical impulse here. So I'll go ahead and palpate. It's usually on the left side of the chest, close to the midclavicular line. So I'm going to go ahead and palpate, trying to find that apical pulse. There it is. Good. Okay. So I'm going to go ahead and listen to his heart, and I'm going to listen at 5 different areas. So the aortic valve at the second intercostal space on the right sternal border, the pulmonic valve on the left sternal border at the second intercostal space, Erb's point right below that, the tricuspid valve, and then the mitral valve. Okay, I'm gonna listen first with my diaphragm, listening for S1, S2, and then any extra sounds like clicks or gallops. And then I'm gonna listen with the bell of my stethoscope again to hear for any murmurs, okay? So second intercostal space, right sternal border. It's my aortic. Second intercostal space, left sternal border is my pulmonic valve. Erb's point. And tricuspid valve. And then moving outward to my mitral valve. Great. Listen again with the bell. Great. S1 and S2 were audible. I didn't hear any extra sounds or gallops, and no murmurs were detected. So the next thing I'm going to do is palpate his carotid pulse, and then I'm going to auscultate for any bruits. Anytime I'm palpating the carotid pulse, I'll just do one side at a time, okay? So we're going to start over here. 2+, excellent. Right here. Great, 2+. And again, I'll listen with the bell of my stethoscope. Great, I didn't hear any bruits. Okay, so now we're moving on to the abdominal assessment, okay? And as with any assessment, this starts with inspection. So I'm just inspecting his abdomen. It looks nice and flat. I don't see any protrusions or distension, no ascites, and no obvious masses or hernias. The next thing I'm gonna do is auscultate. I'm gonna listen for bowel sounds in all 4 quadrants. And then I'm going to auscultate for bruits in the various arteries within the abdomen. So I'll listen to bowel sounds with the diaphragm on my stethoscope. And I'll start in the right lower quadrant and move in a clockwise direction. Great. Bowel sounds are normoactive to all quadrants. If I did not hear any bowel sounds, I would have to listen for at least 5 minutes to confirm that finding. Next, I'll listen for bruits, first in the abdominal aorta. So I'm gonna listen with the bell of my stethoscope because it picks up our lower pitched sounds. So I'll listen between the xiphoid process and his umbilicus. I can actually see a little pulse from his abdominal aorta, so I'll listen for any bruits here. And I don't hear any. And then right above his umbilicus, about 2 centimeters to either side will be his renal arteries. I'll listen for bruits there. And the other side. And then below the umbilicus, 2 centimeters on either side, we'll listen for the iliac arteries. And then we'll listen at his femoral arteries. And I did not hear any bruits. All right, next we're gonna move on to percussion of the abdomen. So I'm gonna percuss all over throughout all 4 quadrants. I'm listening again for tympany or areas of dullness. I would expect to hear dullness over the liver and tympany everywhere else. Okay, so we'll percuss. I'm hearing tympany. And there's my dullness over the liver. Are you doing okay?
Mm-hmm.
Okay. Next, we'll move on to light palpation. I want you to tell me if you feel any tenderness, okay?
Okay.
Okay. Any tenderness?
No.
Okay. Feeling for any masses or anything like that, which I did not feel. So next we'll go ahead and I'm gonna palpate your liver, Kelly. So what I'm gonna do is I'm gonna look for the end of his ribs here, and I'm actually gonna try to cup my hands around his ribs as he takes a deep breath in and try to palpate the liver edge, okay? So I'm gonna find his ribs here and then hook my hands kind of underneath, and I'll have you take a deep breath in and out. Great. And it's slightly palpable, just the edge. Okay, I'll have you sit up and actually turn around so I can palpate your spleen. Now the spleen is not normally palpable. So what I'll do is I'm gonna have you put this arm above your head. And then again, I'm finding where his ribs end here and putting one hand here and one hand beneath him. So I'm gonna try to, as he takes a deep breath, bring these hands together and see if I can capture the spleen. So I'll have you take a breath out and now breathe in. All right, I did not palpate a spleen, which tells me that it's not enlarged, okay? Great, Kelly, so I'll have you sit up again and we're gonna palpate for costovertebral angle tenderness, which could indicate pyelonephritis. So I guess I'll start on this side. I'm gonna put one hand at his costovertebral angle here and then just press here. Any tenderness with that?
No.
Move to the other side. Again, finding his costovertebral angle. Any tenderness?
No.
Okay. Now the last thing I'm gonna do, the last couple of things, I'll palpate his pulses. So I'm gonna palpate his brachial, radial, dorsalis, pedis, and posterior tibialis pulses. So I'll start on this arm, finding his brachial pulse here. Great, 2+, to his radial pulse, 2+, we'll move to this side, 2+, and his radial pulse, 2+. Now I'll grab your ankle here. On the interior of this bone here is that posterior tibialis, 2+, and then if you'll set your foot down right on top here, that dorsalis pedis, 2+. Okay, we'll move to this foot. Again, on the interior, easy 2+, all right. I'll have you 2+, fantastic. All right, so lastly, I'm gonna palpate for lower extremity edema. So I'm just using the pads of my fingers and I'm pressing in gently on his legs. I'm looking for any signs of pitting where it leaves a little indent in his skin, which I don't see anywhere on this leg. I'll go ahead and check this leg as well. No signs of pitting. Great, well that finishes up our assessment. Okay, so I'll do some more hand hygiene. Thank you so much for being my patient today. And that completes our assessment.